Welcome everyone to our symposium, Anti-Racism in Public Health Policies, Practice, and Research. This is a symposium organized by the FXB Center for Health and Human Rights at Harvard University. Over the last year, we've experienced a national reckoning around structural racism. As a culmination of our ongoing conversations around structural racism and social determinants of health, and the need for change, this reckoning led my colleagues and I to declare that racism is a public health crisis and to examine what we can do in academia and renew the Harvard Chan School of Public Health's commitment to address this pervasive issue. As public health professionals and scholars, we at the Harvard Chan School are committed to equity and social justice, both in our work and in our interactions with the people we serve. We're committed to addressing and continuing systemic discrimination in our society and the resulting health-related disparities. And I believe that the public health community can be a force for good, can be a force in dismantling the systemic racism and the pernicious structural barriers that exist in the United States. Despite the remaining challenges, we have a unique opportunity now to make a systemic difference. I'd just like to mention a few examples from the school, our Office of Diversity and Inclusion, also known as ODI. Our office is carrying forward the important work of increasing equity, diversity, inclusion, and belonging in our community. And the office is ensuring that all of our members thrive and feel supported. The office serves students, faculty, fellows, staff, and researchers through a range of activities, while also working to address systemic and structural barriers limiting diversity in public health at all levels, from the undergraduate level to the faculty and administrative levels. The ODI team works with various Harvard Chan departments, academic departments, as well as administrative departments on raising awareness about the many ways that structural racism negatively impacts health and well-being. The team has prepared a strategic plan highlighting a set of goals and objectives to serve as a roadmap for the next 3 years. As part of this plan, several initiatives will be implemented this academic year, including unconscious bias training modules for students, staff, faculty, and academic appointees. The Racial Literacy Course Redesign Project, which will focus on course redesign with a critical race lens and racially inclusive learning experiences. And the Diversity Facilitator Training Program to engage our community in diversity-based developmental activities. While we've taken steps with planning the new programs, there is certainly much more work ahead of us. Enacting change for greater equity and advancing our diversity agenda at the school and beyond will require persistence and dedication. But it's my belief that by bringing an equity lens to everything we do, we'll be able to address with guided effort our challenges and opportunities for growth and advancement for everyone. In order to strengthen our vital work in global health and health equity, I've recently appointed Dr. Loomis Hilaire to serve as Assistant Dean for Population Health Management and Health Equity Education. Loomis's work will be highly collaborative. He will partner with faculty, staff, and administrators across the school on existing research and educational programs, such as certificate and degree programs for public health and business leadership, as well as our new program in Harvard Global Nursing Leadership Program. Another example of what we're doing here at the school is that we've recruited Dr. Kismekia to join the school's faculty. She will establish an independent research program on emerging infectious disease, and she will continue her work on vaccine development research. Dr. Covet is an outstanding viral immunologist who was directly involved in the groundbreaking research that led to the development of the mRNA 1273 Moderna vaccine. In her words, vaccines are the great equalizer when it comes to addressing health disparities, especially around infectious disease. And I couldn't agree more with this statement. I'm proud of the work that's taken place to date. We've taken a deep look at the present opportunity to address the hard societal issues that the pandemic has exposed in order to advance health equity for the most vulnerable. We've also had an opportunity and an obligation to critically examine how the research community can do better to integrate health solutions for the society to make it through the current crisis and to improve the health and well-being of populations worldwide. As we look forward, a whole program designed around structural racism and its enduring impact on health is a necessary next step. Today, I congratulate our colleagues at the FXB Center as they announce this bold, this important next step. As you'll hear more about today, the FXB Center aims to create an actionable field of scholarship examining the impact of structural racism on public health. The center will also work to build ties with our neighbors, decision makers, community organizations, media, and government partners to ensure this research appears not only in academic journals, but that it is also communicated in ways that will help guide change. This is a moral imperative. This is a moral imperative to ensure that we achieve equity. We don't have to show that racism underlies shorter, less healthy lives to agree it should end. But we can show this. We can and we should do so as rigorously as we possibly can. So, what public health can add to the call to end structural racism is research and data showing racism as a root cause of health equity, a determinant of health, and a health stressor in and of itself. Such data will inform life-saving actions and decisions at the structural level. The Harvard Chan School has a real opportunity to lead on this issue, especially with experts like former New York City Health Commissioner, Dr. Mary Bassett. With Dr. Bassett at the helm, I look forward to seeing what comes next. There is a great lineup of speakers today at this symposium, and the discussion I know will be compelling. As the pandemic has exacerbated the long-term racial, economic, social, environmental, and health disparities in our society, we look forward to hearing our speakers' insights on how our collective action, our collective efforts can make a systemic difference in order to advance health equity, serve all communities, and progress towards a healthier and more sustainable future. I think that such conversations provide an opportunity to amplify our collective voice in the name of public health and social justice. For those of you watching, I hope you leave this symposium with a clear understanding of how public health practitioners can help to dismantle structural racism. Most importantly, I hope you will leave the symposium inspired to join us in our work. Now, allow me to introduce Barbara Pickauer, President and Chair of the Board of Directors of the JPB Foundation. A longtime supporter of the school, Barbara has been an instrumental member and advisor to me as a member of our Board of Dean's Advisors. Through the generous support of the JPB Foundation, she has enabled the FXB Center to launch this exciting new area of work on racial justice and health. Barbara, I'd like to take this moment to thank you publicly, and also, Mary, to thank you and the FXB Center for leading this important work. And now I turn the mic over to you, Barbara.
Well, you are a hard act to follow, but I will try. Thank you very much for inviting me to be part of this. For those of you who do not know much about JPB, we are a foundation. I have been in this business for 30, 40 years. This branch of the foundation is celebrating its 10th anniversary, and we specialize in 3 areas, which are barriers to health, environment, and medical research. One of the things that we are going to be really concentrating on this coming year is injustice. And we are looking at injustice from every point of view that we can. So that means health, it means education, it means gender, it means race, it means everything. And we don't think that there's been enough attention to it. And that is one of the reasons that JPB was very excited about supporting Mary Bassett. I've known Mary for, oh God, tons of years, back from when she was in the medical, she was the medical commissioner of the city of New York. I'd like to feel I had a role in convincing her that she should leave that job, but forget that I said that, because that's not such a good thing to say when you operate out of New York City. But that she found a role that is excellent for her and can really help us. And I am very much looking forward to today. And I don't know, does Michelle come back, or do I introduce Mary? I think somebody else will introduce
Thank you, and I appear. Thank you so much.
Well, thank you very much, and I know this will be a great day.
Great. Thank you so much, Barbara. And thanks. You're welcome to stay as long as you're able, both Dean Williams and Barbara Pickauer. And for people joining us, I want to begin by saying good morning. And maybe for some of you, it's good afternoon, good evening. I'm Dr. Mary Bassett, and I direct the Francois Xavier Bagnoud Center for Health and Human Rights at Harvard University. The number of COVID deaths has now surpassed 675,000. That's the estimated US death toll during the 1918 flu pandemic. And in many ways, this pandemic has pulled back the curtain on how we are doing as a nation. And the answer is not so well. But at the same time, as both Dean Williams and Barbara have mentioned, the year 2020, an unprecedented year for many of us, saw more people embrace the idea that we need to tackle racism in the United States than I've seen in 50 years. And this shift can be attributed to an understanding that it was racism that linked 2 central events in 2020. First, the observed stark racial inequities in COVID mortality that emerged early on and tragically still persist. That injustice was compounded by the very public murder of George Floyd. And together, these sparked protests not only in the United States, and we are going global today, those protests also extended around the globe, where similar patterns were observed, with racial and ethnic minorities suffering and dying from COVID at much higher rates than the majority population. In 2015, that far back, in an article in the New England Journal when I was the New York City Health Commissioner, I explained there is great injustice in the daily violence experienced by young Black men, but the tragedy of lives cut short is not accounted for entirely or even mostly by violence. In New York City, the rate of premature death is 50% higher among Black men than among white men. And I went on, this gap reflects dramatic disparities in many health outcomes, including cardiovascular disease, cancer, HIV. These common medical conditions take life slowly and quietly, but just as unfairly. What I was trying to suggest was that health inequities are often an invisible form of structural violence that health professionals should be speaking out about. COVID made that visible. And maybe for the first time, not only health professionals, but people around the globe are seeing the parallels and able to clearly articulate that racism kills. As 2021 unfolds and COVID continues to take lives and disrupt livelihoods, especially for Black, Latinx, Indigenous, and other communities of color, a focus on structural racism remains critically important, and we must talk about our history in order to have a chance to build a better future. While the pandemic is ongoing, especially in many parts of the globe where vaccine access has been denied, it's also created new ways to come together virtually, like this webinar. So I'm so glad that all of you have joined us today for anti-racism in public health policies, practice, and research. And I thank our Dean, Michelle Williams, for her steadfast commitment to creating a more diverse and inclusive academic community. She's outlined it for all of us. And she sees this as central to pursuing the school's goal of academic excellence. And I thank you also, Dean Williams, for your kind remarks about our center and me. The JPB Foundation made possible for the FXB Center to recruit a crop of talented young fellows. I don't use this word crop casually or derisively. We need to encourage growth, and growth that will yield new ideas to overcome our many painful legacies. And it's my hope that this new racial justice program plants a seed, and we are privileged and humbled that the JPB Foundation agreed. This is a JPB Foundation award, but I also want to acknowledge the personal role of Barbara Pickauer and the role that she's played in responding to the events of 2020 by supporting a whole host of innovative programs, a lens that she's told us today JPB will continue. So Barbara, I thank you for never getting tired. And the FXB Center was founded over 25 years ago, thanks to Albina de Bois-Rouvray, whose vision was matched by her generosity. The FXB Racial Justice Program focuses on US racism and is a new endeavor at the FXB Center, which is focused largely on human rights and health issues outside of the United States. Of course, the US is not alone in its embrace of a racial hierarchy, and the pioneering FXB Roma program, established 10 years ago, has consistently characterized the treatment of the Roma as racism. The Roma program has collaborated with activists and scholars involved in interrelated struggles for rights, justice, equality, dignity of various racialized oppressed groups across the world, mainstreaming Roma-related issues within the broader anti-racist movement that includes the struggles of the Dalit, once known as untouchables, Black Americans, and other marginalized and stigmatized populations. And it's also not hard to see how racism affects other work at FXB, including the so-called migration crisis, which affects populations across the globe, and vulnerable children whose access to protection is increasingly precarious. The FXB also recognizes that the US has its own human rights issues. Nowadays, lots of people invoke structural racism and its allied concept of systemic racism. But what do we mean by these words? And how do we move away from the idea that structural racism is some sort of modern day miasma? This was a 19th century idea that disease was caused by these clouds of treatment and bad clouds that were in the air that cause disease and were just about otherwise unknowable. That's where our fellows come in. If I could have the first slide. We now have 7 health and human rights fellows, 2 of whom, the ones shown from your left, are in their 2nd year. Dr. Vasula Djadiki Lucero has a doctorate in clinical social psychology and focuses on migration and child well-being. And Dr. Justin Feldman, next over, is a social epidemiologist who has worked on the carceral state and aspect of structural racism. And he's also helping to coordinate the new fellows. And then there are 5 new fellows. If I could have the next slide, I have them organized alphabetically by last name. That's for the fellows in case they wonder. And I want to introduce them to all of you. Dr. Brittany Butler, who uses mixed methods to bring together quantitative and qualitative data and explore how neighborhood contexts affect maternal health outcomes of Black women who experience truly unacceptable rates of maternal mortality. She's used pregnancy induced hypertension as her main outcome of interest. And she's also a Bell Fellow at the Harvard Population Center, a joint appointment that will help build connections between our 2 centers. Tori Cowger is also a social epidemiologist and uses an array of cutting-edge methods to examine the spatial distribution of fatal overdose, considering urbanicity, geography, time, in addition to race and gender. And she'll be defending her dissertation this fall and will join us then. Dr. Jordan Lawrence has worked on discrimination and its health effects in a dissertation that also included novel methods. And she's now hard at work thinking and learning about a data set that will allow examination of the potential health benefits of reducing the Black-white wealth gap that could be addressed through reparations. And next we have Coletza Makofane, originally from South Africa with a background as an HIV/AIDS activist. Coletza used his dissertation to explore how family networks that link up individuals. Most people have family ties that form an important context in which any single individual's health is embedded, and how to capture this. Called on Coletza to develop and deploy novel analytical methods, and important insights emerge relevant to causal inference. And last but not least is Dr. Marie Plissime, a medical sociologist who focuses on structural features of medical care that drive unequal treatment, from medical school curricula to algorithms to technology that's based on representations of white bodies. And she uses mainly qualitative methods. She's also the recipient of a National Science Foundation Award, a project in which she's mentored by Dorothy Roberts, a leading thinker on race-based medicine. W.E.B. Du Bois, one of our nation's 20th century giants, pointed out over a century ago in his study, The Philadelphia Negro, that it was racially targeted deprivation that accounted for observed poor health among Black Philadelphians. And today, over a century later, it still seems important to me to point out to all of you that the health experience of Black, Latinx, Indigenous, and Asian people reflects what happens to people confronting long-standing, relentless adversity. These health inequities are not rooted in cultural quirks and certainly have nothing to do with biological differences. As someone who's been thinking about racism for a very long time, I take great encouragement for our collective futures from the fact that the fellows have decided to focus on these topics, which remain less conventional and less safe than the traditional academic focus on risk factors and diseases. These fellows are brilliant, rigorous thinkers. They are set to challenge the idea that calling racism a public health threat is simply some kind of slogan. Instead, they are continuing to build the intellectual foundations of an idea advanced by Professor Nancy Krieger, who's on our faculty and will be joining us today, that understanding how societal arrangements get into our bodies and affect our health is of interest to all people. Last, we all know that the best public health research occurs in dialogue with those whose communities bear an excess burden of ill health. So joining the fellows is Amy Takanami, a community organizer, a passion that she shares with Natalia Linos, the executive director of FXB. So here we are. We are at the beginning of this endeavor. And my challenge to all of us is to get started. We are delighted to pass the virtual mic now to Dr. Margareta Mataki, who is an exemplary activist, scholar, and the director of the Roma program that I mentioned previously. Magda is going to moderate the first session, and over to you, Magda. Thank you very much.
Thank you so much for your kind words of introduction, Dr. Bassett. Hello, everyone, and welcome to our symposium, Anti-Racism in Public Health Policies, Practice, and Research. Today, as Dr. Bassett mentioned, our team at the FXB Center is launching a racial justice initiative that aims to examine racism as a structural determinant of health. And while the FXB Racial Justice Fellows will engage in proposing and testing research methods that measure present-day consequences of racism, today we want to kick off this symposium with a discussion on racism and health in history, with two acclaimed and groundbreaking historians, Professor Evelyn Hammond and Professor Khalil Gibran Mohammed. Professor Hammond and Professor Mohammed, it is a great honor to have you with us, to have you as our guest. Welcome and thank you for joining us.
It's a pleasure to be here. Thank you, Dr. Mataki.
We have only about 30 minutes, so I will introduce the panelists briefly, and we will also post their full bios in the chat. Professor Evelyn Hammond is the chair of the Department of the History of Science, professor of the History of Science and of African and African American Studies at Harvard University. Professor Khalil Gibran Mohammed is professor of history, race, and public policy at the Harvard Kennedy School and the director of the Institutional Anti-Racism and Accountability Project at Harvard. Let's jump right into it and start with our first question. Today, the FXB Center is launching a program that examines how structural racism impacts health. Why is it important to include history and historians in such initiatives? I'd like to invite you both to respond to this question, and perhaps Professor Hammond, would you like to start?
Sure. Thank you very much. Why history matters is a question that I always enjoy answering. But seriously, I think that in order to understand how racism became such a institution, how racism became deeply embedded in American institutions, you have to look at it historically. And public health and medicine are certainly institutions where this has certainly been true. And since the very beginning of the American project in the early 17th century, unequal access to healthcare has been a predominant feature. And so in order to understand what we have to do now in the 21st century to dismantle structural racism, I think requires that we understand how it came to be a part of medicine and public health, and how, and therefore gives us real guides to what we have to do to dismantle it. So that's just the general overview of how I think about my work and why history matters. But I also think it's important because most people simply do not understand this history. They don't know it. They haven't understood it. And so it's easy to, at this point, to resort to kind of simple-minded and facile sort of recommendations for how we might be anti-racist right now. When I don't think you can be anti-racist if you don't understand racism itself and the history of how it's structured our public health system. So that's why I think the history matters. And I think it's really important to me to be a part of this program today to help us think about the actual details of how the history matters.
Thanks so much for the question, and thanks for inviting me to participate. And it's a real honor to be here with Professor Hammonds. Her work in the history of science has been influential to at least a generation of scholars who are interested in these questions. I include myself among them. And also to just acknowledge that this work is hidden in plain sight. So these are not histories that are buried in archives. Some of them are, and a lot of good work remains to be done. But really, to be frank, one of the reasons history is so important to this conversation is because if we go to kind of the moment of modern science, particularly in the United States, which coincides more or less with the mid to late 19th century, the clinical practitioners and the academic researchers were aligned around a consensus that health itself was a scarce commodity, that the tools of medical intervention themselves were to be distributed in ways that met with the urgency of ranking people according to their usefulness. And to be even more precise in my own distillation of this history, we might think today that the problem is just an access problem. And maybe we could all agree on some moment in the past 10, 15, 20, 30 years when that happened. But for the weight of history, non-European bodies were raw material for notions of progress and civilization. That raw material took the form of labor extraction, but it also took the form of medical experimentation. Mm-hmm. And so if we understand that history in the fullness, in the way in which it unfolded, we'd be much more cautious in a kind of goodwill effort of people to simply add Black people or brown people or Indigenous people to our medical systems. I'm reminded, for example, that in the midst of the height of COVID last year, when questions about where testing sites could be placed, those decisions were overlaid on top of structural racism that meant that the private healthcare system was already a symptom of deep and longstanding inequalities. And so people had to cross highways in Houston, for example, to get access to testing. People who didn't have cars couldn't move or go to drive-through COVID testing sites in the way that many suburbanites could. The other example that I'm reminded of is in Brooklyn, for example, there was a public hospital that was literally falling apart that had been built in the 1960s and had about 50 years of deferred maintenance, and it was ground zero for the essential workers of New York City. And yet across town in Manhattan, private jets were used to fly in PPE for people who needed protection in the midst of doing the primary care and delivery. These moments that we bore witness to in the past year are the structural legacies of the project of saying some bodies simply are not important when it comes to longevity and health and fitness. And so the medical profession, as well as the public health sector, are deeply implicated in that history and have a lot of work to do, not only to dismantle it, but to create the kind of professional standards and credentialing processes and continuing education that would close the gap between the intentionality of scientific racism and structural racism and the choices that we can make today.
Mm-hmm. Thank you so much. And I think that if I were to have a short conclusion of your comments, I think that what we need to understand is indeed that people do not understand the history, especially the history of Black Americans in this American project. And yet what we've seen in the past few years, it's a war against the history of Black Americans being taught in schools under the gaze of this war against critical race theory. And I hope that we get a chance to talk about that later on as well. But I will move on to our next question, and I will invite you again I will invite both of you to respond again. So Professor Hammonds and Professor Mohammed, what are the historical causes of Black-white health inequities? Maybe Professor Mohammed, would you like to start this time around?
Well, I really do think Professor Hammond should set the table because this is her work through and through. So I'm going to defer to her, and then I will complement her response.
Okay. Thank you, Khalil. You know, I think one important fact to understand about this history, there have always been health disparities in the United States. There's never been a moment where there weren't disparities between the health of white Americans and the health of Black Americans, Latinx people, and Indigenous people in this country. There simply is no such point. And I think that's one of the most important things you have to understand about the history. Certainly in the period of chattel slavery, up until the end of the 19th century, enslaved peoples were never allowed to engage in health, to receive, I should say, the health care that they deserved, because the only reason on plantations that a plantation owner would call for a physician to come and take care of his people, the enslaved Africans, was because they wanted to keep them working. So the only thing they cared about was supporting their labor, and that was it. It wasn't about real healthcare. And in the period when public health infrastructure was in its infancy is also the same period of time when ideas about differences between Black and white bodies were used to not provide any healthcare or any kind of public health relief for African-American communities that were suffering from various kinds of diseases in the post-slavery period. And it's certainly in the moment of Reconstruction, at the moment when the Civil War was over, when Black people were freed, and they were beginning to find their way into broader aspects of the country and also into American society, was exactly the time when public health turned its back on the needs of these people. There were smallpox epidemics in the end of the 19th century. There were epidemics of cholera, all of these kinds of things. And the public health system that we had at the time simply said, well, Black people die because they're Black. Black people are different and they die. We don't have to do anything to try to help them. And even when African Americans were trying to help themselves and appeal to the national government in the late 19th century, arguing that now that enslaved peoples were free, that citizens deserve the right to have the government provide healthcare and public health to them. And at the time, the national government, for a very short period of time, did try to do that with the use of the Freedmen's Bureau to try to have some kind of redress to the extensive suffering of newly freed peoples at the end of the Civil War. That was short-lived. By the early 20th century, the national government had retreated from feeling that there was any way in which they could step in to help formerly enslaved peoples to have better health throughout the country. And here I think is an important part to remember about this particular time. Our public health system has always been fragmented. And so the ways in which local states, towns and states really put forward public health relief in times of outbreaks of disease, for sure. Those states in the old Confederacy had no interest in providing public health relief to communities of African Americans, Latinx peoples, Indigenous peoples at all. Until this sort of the dictum became germs know no color line. So when it became clear that, infectious diseases could lodge in poor and under-resourced communities of Black people, of brown people, of Indigenous peoples, The idea was we will, as public health experts, we want to control the spread of those diseases in those communities just to protect white people from getting those diseases, not necessarily to help Black people. And so that to me is an important moment in the early 20th century when decisions were constantly being made by public health leaders that the only reason expenditures for public health would happen would be to protect the white people, but not to protect other groups of people of color and also poor white people. So, you know, where do health disparities come from? They come from those kinds of practices. They come from those kinds of decisions that meant by the early 20th century, you have a huge gap in the health status of peoples of color and white people in this country. And you have it in extreme forms in states of the old Confederacy because they did not have any pressure put on them to provide public health for communities that were suffering from disease that were not white. It takes a change in that kind of approach to public health, which doesn't come for a very long time. I would even argue doesn't really begin to be taken quite seriously until after World War II. And that by that time you have African Americans who are now studying public health, who are practicing in public health institutions, as well as increasing numbers of physicians and nurses. And they didn't have a voice to say this is the inequities that we see here cannot stand. But before then, that was not so much the case. And I think, so if you think about that for the first half of the 20th century, public health leaders tend to turn their back against poor people, and certainly for African Americans and other people of color, then it's not too hard to figure out where the disparities come in. And certainly, as Mary Bassett said earlier, people like W.E.B. Du Bois, people like W. Montague Cobb, who were African American sociologists and physicians who looked and said, we can see that this sort of structural disenfranchisement of certainly for African American peoples is the key to why we see so much disease in these communities that is uncontrolled, and it affects the health of Black peoples. So I'll leave it there. There's a lot more to say about that, but I think the point is that it became sedimented, I think, in the early 20th century, that public health leaders did not have a mandate to end the kind of structures that resulted in the disparities, which they could see were related to living conditions, to access to jobs, to poor working conditions, and all of the kinds of things that we now would refer to as social determinants of health. Those things were evident in the early 20th century.
That's great, and really wonderful to have such a comprehensive a way of understanding the broad historical drivers. I want to just really emphasize one key theme and use the lens of tuberculosis as a contagious disease in the early 20th century, for which a lot of public health resources were directed. What's fascinating about this history, some of which I know as a researcher, others of which I know from reading the work of others, is that it was both, as Dr. Hammonds has already described, a contagious disease that people clearly understood for low-income urban residents in particular. Their proximity to middle-class, often in this case white people, meant that the disease spread was their concern as much as it was the problem of, as my historian colleague Tara Hunter has written about, the Negro servants disease. Yes. So the ascription of something like tuberculosis as being caused by the presence of Black people in proximity to better off whites was echoed in the corridors of New York City with regard to Italian immigrants. Philadelphia had its so-called alley problem, which were places of high density and unhygienic living conditions. But here's the thing. The public health community outside of the South with regard to Black people, but in places of European immigrants, eventually made an argument that to address the spread of tuberculosis would be to improve the living conditions, the physical infrastructure of what are people who would eventually be defined as white Americans. There's a lot of history of the indeterminacy of various European immigrant groups. But the point is that the public health sector did get its charge to deal with this problem because these were people who couldn't be segregated by color in a way that you never know that the immigrant next to you had tuberculosis or not. The lesson from this history is that systems did respond to the presence of Chinese immigrants in San Francisco who bore the kind of burden of a similar anti-Black racism, which was more about quarantine segregation. But it was eventually a system called the immigration system that dealt with that problem. That is to first restrict access to the country altogether through the Exclusion Act, and later to attempt deportation of Chinese immigrants. And the point I want to emphasize is that while people of European ancestry, even if they weren't all considered worthy or desirable, did eventually get public health resources, other groups were treated to forms of public policy that were immigration exclusion, were deportation, were criminal justice responses, were forms of quarantine and segregation. So it's not to say that the nation didn't respond to these health disparities. They responded often in punitive and exclusionary ways that teaches us that the relationship of health is not something that simply was ignored. It was dealt with, but it was dealt with often in quite contrary ways. The whole eugenics movement itself was predicated in part on the understanding of the predisposition of disease of various groups. And of course, there's tremendous circular logic to all of these histories, because as we understand today, the structural oppression that contributed to the problem is ignored the symptoms of the problem that show up in mortality and morbidity statistics, then become a justification for more structural oppression and isolation for non-white populations. Again, from isolation, quarantine, segregation, to, of course, more punitive responses from immigration to criminal justice. So that's an important way of understanding this, this history that I think, again, points us to some of the ways in which our systems today that are not in the public health sector continue to respond to these health disparities.
Thank you both. And I know that, responding to these questions in a few minutes doesn't really, make justice to the topic. And in fact, perhaps to stay a little more on that thought, I like to follow up with a few questions. And Professor Hammonds, you talked earlier about the public health leaders who turned their back to Black people and people of color in the United States, and this whole history. And I remember that in 2019, you co-authored a paper in which you underlined that much of the scholarship on health disparities discounts the historical past. Mm-hmm. And indeed, the field of public health, the discipline of public health, has accepted and examined education, income, housing as social determinants of health. But knowing that all social determinants are filtered to the harm of structural racism and history, mm-hmm. Perhaps could you talk a little bit about the reasons why is the public health scholarship silent on racism as a structural determinant of health and on history?
Well, I don't think that public health literature has been silent on racism and history in, I would say, about the last 20 something years, or maybe even closer to 30. But the ways in which the history is used and deployed to be put in the service of the conversations that are happening right now, I have found to be somewhat difficult to understand. And let me just use Du Bois again. So in the American Journal of Public Health, as you well know, there's a section called Public Health Then and Now. And it's the place where historians of public health and medicine often published articles about, various historical episodes. For example, discussions about tuberculosis and immigrant populations in the early 20th century, late 19th century. You'll find those kinds of articles in Public Health Then and Now. But what I find interesting is how it's sort of located in Public Health Then and Now, but not necessarily well integrated in contemporary articles until fairly recently. But the other one that I would mention is not just W.E.B. Du Bois's Philadelphia Negro, but his other publication called Health and Physique of the Negro American. And in that, he goes through carefully lots of data from physicians, from funeral home owners, from any kinds of public records that he can find to try to chart the health conditions of African Americans around in the early 20th century. It's incredibly thorough. It's a rich compilation of data because he wanted to refute the sort of general observations that white scholars in public health and in sociology would typically look and say, well, those Black people are simply dying because they are inferior peoples. They can't survive in the civilized society. And he said, no, we have to collect the data, and we have to understand morbidity and mortality rates, the living conditions of people of color, of Black people specifically. And then we have to think about what we see after we get all of this data. And it's a wonderful compilation. I don't think many people have even read Health and Physique of the Negro American or the Philadelphia Negro, where he goes, in the Philadelphia Negro, he has maps of neighborhood by neighborhood, practically house by house. And so, but Du Bois's views that you have to do that kind of fine-grained analysis in order to understand, and not just resort to simple notions of these kinds of Black-white differences exist because white people are superior to Black people, or Black bodies are just fundamentally different than white bodies, but actually you use the data to do so. And in the tradition of people like David Williams, who's been doing this his whole career, and you'll hear from him later today, is that the data was there to be captured and to be discussed, but it was not. And so even by the 1970s, there are historians who write and say, look, in the state of North Carolina, where public health efforts were regularly lauded as being one of the best places in the South, where public health efforts had resulted in a decrease in mortality and morbidity. At the same time, the gap between white and Blacks was almost the same in the 1970s as it was in 1900. So you have to ask, so in what ways was the information about what it would take to improve the health status of Black populations, why wasn't that seen and understood and reacted to in positive ways by public health leaders, not just in the South, but in rural South, but also in urban areas? So that's been disturbing to me, because many people tried to collect this data. And as W. Montague Cobb said about Du Bois's work, he said as if he kicked a football and across the field and it landed nowhere. It just wasn't picked up by public health leaders at the time. So I think the history is really important. Also about the need to take public health prevention efforts to the people. So certainly in the early 1940s, the African American sorority Alpha Kappa Alpha, they created, they had a mobile sort of public health van. It was actually a big car, and they took lots of, sort of basic medicines to people living, Black people living in the South. And they knew that if they didn't do that, those people would never have access to drugs that could have helped them. And they had no other access to the kinds of treatments and medical care that they needed. And does that tell you something when we look and see COVID rates in Mississippi right now? Because the infrastructure, the public health infrastructure in Mississippi is still very, very poor. And access to the best possible interventions, both for prevention and for just treatment, is still very weak. Why do we allow this fragmentation? I think this fragmentation such that in some places, Massachusetts, you can get pretty good care, even though there are lots of gaps. But in a place like Mississippi, healthcare and public health interventions are very, very weak. Why do we allow that to happen? And as I said, the information that we needed, the data that we need, the analysis of what happened with efforts in the past is not news. It's there. It's been there the whole time for people to build upon, to develop better and more sophisticated methods. And in some cases that has happened, but in other cases that has not happened at all. So I think it's really important to pay attention to the history. As I said, I think every public health school should be teaching health and physique of the Negro and also the Philadelphia Negro. If you want to understand how to think about and build upon analyses to redress what has happened for African Americans and certainly parallels with other groups, then you need to understand those two analyses that Du Bois did a very long time ago.
Thank you so much, Professor Hammonds, and I hope that our racial justice fellows will have the chance to continue this conversation with you in the next years and include the history in their quantitative and qualitative research. Professor Mohammed, I have one last question for you. And I remember that in a recent interview, as much as in your writings and your class at Harvard, which I was honored to take years ago, you talk about the history of racism in the United States and its nexus to policing. Nowadays, equipped with technology and smartphones, we witness more police violence and killings. Police officers replacing mental health experts and services, as well as a growth of incarceration. Do the police pose a threat on the health of Black Americans, Professor Mohammed?
Yes, that's pretty straightforward one to answer. And how do we know this? We know this because if we listen to the self-reported experiences of people who face high rates of police contact in communities across the United States, or we read Department of Justice investigative reports now spanning 25 years of evidence, as well as multiple consent decrees that grew out of the reports on various constitutional violations from police contact, civil rights abuses, or we read the commission studies that are now 100 years old, going back to Chicago, or the Kerner Commission report, or various reports on New York City and Los Angeles in the 1990s and 2000s, we recognize that state-sanctioned violence is itself a public health problem and threat and emergency. And the conditions of confinement, of course, have led to reports from Amnesty International, various human rights abuses. National Academies of Sciences has looked at this, particularly in the midst of COVID. I apologize, my phone's across the office and for some reason someone's calling me. So the evidence is absolutely clear that the way that we respond to structural inequalities with criminal justice sanctions is itself a contributor to not only disparities, but poor health outcomes, including mental health problems. And again, I just want to close on this point by echoing something that Dr. Hammonds just said. Data on disparity does not in and of itself make the case for how to interpret it or what to do about it. And the difference between scientific racists and leaders in clinical practice 50 years ago, sort of at the height of formal segregation in America, who were often quite intentional about reading the evidence as evidence of inferiority. Today, those voices are more muted. They've risen again in the context of white nationalists organizing this country, and certainly the former president was more or less clear about how he understood immigrants, for example, from Africa as a threat to the nation's interests. So we have to be mindful that because our language changes doesn't mean our intentions haven't. And that's the work of our professional schools, to ensure that people won't slip into what I teach my students, a kind of magical thinking, where the disparities really are about the sum total of individual choices that people make, even to put themselves in the position of living in a quote unquote high crime area. Students sometimes think of, well, Black people just want to live next to Black people, so of course they pick these communities. I've dealt with this logic for 30 years. So we have to be clear that yes, the disparities exist, the data exists, it goes back to the Philadelphia Negro, but Du Bois was literally dismissed out of hand as being overly sympathetic and biased towards his own people. And there's still that concern today about people like Dr. Hammonds and me and Dr. Williams and so many others, whose personal commitments to this work blinds us to the hard facts of the evidence as it is presented about, personal behavior and cultural predispositions. So the challenge that Du Bois faced is still the challenge of our time, and it's up to a new generation of scholars and administrators and activists and so on to perhaps win the argument in the future. I hope they do.
Thank you so much, Professor Mohammed. And with that, this is where we will end this conversation. And I do wish we had more time. But Professor Mohammed and Professor Hammond, thank you so much for your insights and for helping us frame and understand the importance of history in examining racism as a determinant of health. And thank you all for joining us. And now I'll pass back the mic to Dr. Bassett.
Thank you.
Thank you. And let me echo Magda's words of thanks. This was really a fascinating conversation and just continues to remind me how important it is to know our history and how recurrent the arguments have been about what the root causes are of poor health among people of color. So we're now going to move on and agree that there's much more to say and talk about. And I am going to pass the virtual mic now to Professor Baba, who will introduce the next panel, after which we'll have a bit of a break, I think. The next panel is entitled The Public Health Emergency Across the World. It will be moderated by Professor Baba, who is a human rights lawyer, I think first and foremost. She also directs research at the FXB Center, where she is a professor of the practice of health and human rights at the Chan School of Public Health. Over to you, Professor Baba.
Thank you very much, Dr. Bassett, and thank you to all the organizers of this really remarkable and I think unprecedented event, certainly for the FXB Center. I'm delighted to be a part of it. So as you just heard, our panel, the second panel that we're going to have, is entitled Racism, a Public Health Emergency Across the World. And in opening our discussion, I'd like to pause for a moment on the word emergency. According to the Oxford English Dictionary definition, an emergency is, and I quote, a sudden, serious, and dangerous event or situation which needs immediate action to deal with it. Comes from the Latin emergens, to rise up or to rise out. So according to this definition, there are two elements to an emergency. It's sudden or unforeseen, and it's serious and requires immediate action. Now, I think the last panel would leave us in absolutely no doubt that racism only fits one of these elements. It's not sudden, it's not unforeseen. It is deliberate and long-lasting. And it's embedded, as we've heard already, and we will hear more, it's embedded in law, in policy, in educational curricula, in social mores, and in the conduct of police and other public officials. And beyond that, many powerful actors in our societies. And we've just heard from, I think, two of the leading experts that this longue durée, as the historians call it, has been the case for centuries. And the fact that what we are dealing with has had such a long and deep history, I think has very serious implications for the kind of remedial action that's needed. And so in this panel, we are going to review some of, I think, what Professor Mohammed just referred to as the hard facts that underpin this, this situation and the remedial action we need. So let's just start for a second with the word racism. In a leading article in the 2019 Annual Review of Public Health, Professor David Williams, who I will introduce in a moment, together with Jordan Lawrence, one of our new fellows, and Bridget Davis, a former member of our FXB graduate student cohort, the three of them describe racism as follows. And I'm just going to read, I think, their very powerful and useful definition. Racism is an organized social system in which the dominant racial group based on an ideology of inferiority, categorizes and ranks people into social groups called races and uses its power to devalue, disempower, and differentially allocate valued societal resources and opportunities to groups defined as inferior. A really powerful, I think, interesting definition. But clearly, one thing it makes clear is that there's nothing sudden or unforeseen about this process, and its impact certainly does create a serious and dangerous situation. So each of our panelists, our three panelists, will address this. And the way that we've organized our panel is slightly different from the preceding one. I'm going to introduce the three panelists in the order in which they're listed in the program that you have. And then I will invite each of them to speak on their work, their research, the hard facts that they have uncovered through their research for about 7 minutes. And then we will engage in brief discussion for about 20 minutes before leaving some time for Q&As. So please do be thinking about the questions that you might want to ask. So let's start with Professor David Williams, who's already been referred to several times. He is the Florence Sprague Norman and Laura Smart Norman Professor of Public Health and the chair of the Department of Social and Behavioral Sciences at our school, at the Harvard Chan School. He's also a professor of African and African American Studies and of Sociology at Harvard University. And he is, as you've already heard, one of the leading authorities on the social influences of health, having done decades of research on the complex and intersecting ways in which racism and other social phenomena affect the physical and mental well-being of individuals and populations. So, Professor Williams, thank you so much for joining us. And if I may just start by asking you my first question. You have researched the ways in which racism, independently of socioeconomic level or education, affects health in many different populations. You've looked at African Americans here in the US. You've also studied sub-Saharan Africans in South Africa and elsewhere on the African continent. And we've learned from you the striking fact that at every level of education and income, African Americans have lower life expectancy at the age of 25 than whites or Latinx people. Why is this?
Thank you so very much. And it's truly an honor and privilege to be here with you today. And I just want to kind of contrast where Americans are in terms of compared to where the scientific evidence is. I'm actually going to share my screen here for a second so that you can see in my slides. I think I'll get through much more quickly. Why does racial inequality exist? What does Americans think about this particular question? This is national data for the United States from a study that was completed back in 2015. And what this study found is that most Americans, almost 2/3 of all groups, whites, blacks, Hispanics, believe that hard work is no guarantee of success. And if you look among the white working class, they even endorse that at a higher level than the highly educated whites. And even if we look across political lines, you find 52% of Republicans and 71% of Democrats agree that working hard alone is no guarantee of success. But when this same national sample was asked, what the solutions to the problems of blacks were, they believed that blacks would do as well as whites if they only tried harder. 50% of whites believe that the problem of inequalities is simply the failure of blacks to try harder. And stunningly, even 43% of blacks believe that, and 48% of Latinos. So it is quite striking, the pattern that in fact exists. The question is, what does the science tell us? And I want to quickly review some of the scientific research and just focus on one mechanism. It's not the only mechanism of structural racism, but a powerful one that I have been very interested in: residential segregation as a central driver of the large racial ethnic differences in opportunity. So I'm drawing here on two colleagues at Harvard University, William Julius Wilson and Robert Sampson. They've reviewed the research, a study of the 171 largest cities in the US, and said because of segregation, there's not even one city where whites live in equal conditions to those of blacks, and that the worst urban context in which whites reside is considerably better than the average context of black communities. Now, that was a 1995 publication, and you wonder, well, how have things changed? Well, Professor Dolores Azevedo Garcia at Brandeis University has created a neighborhood opportunity index, ranking every county in the United States on almost 30 indicators of access to opportunity. Things like the quality of elementary schools and the high school graduation rate and the income level and home ownership level and access to quality air and water, exposure to soil pollution and hazardous waste sites, and access to resources for health like green space and healthy food outlets. So there are 29 different indicators. And what she finds, if you look at the 100 largest metropolitan areas in the United States, 2/3 of all black children, 58% of Latino kids, 53% of Native American kids reside in very poor or poor opportunity neighborhoods, compared to about 1 in 5 white and Asian kids. If you look at the opposite end, who lives in high and very high opportunity neighborhoods, almost 2/3 of white and Asian kids, and about 1 in 5 African American and Latino kids. So segregation has really structured powerfully access to opportunity in the United States. In fact, research finds that segregation itself is the driver of the inequities in income and education and occupational status that we see. This is David Cutler, economist here at Harvard University, using national data, looking at blacks and whites. He shows that statistically, if you could eliminate residential segregation, you would completely erase black-white differences in income, in education, and in unemployment, and reduce black-white differences in single motherhoods by 2/3. All of those stark inequities are driven by opportunity linked to place that was created by residential segregation. More recently, another Harvard economist, Raj Chetty, has asked an intergenerational question. Let's look at black and white kids. Let's compare those who start life in households with similar level of income, and let's see how the next generation is doing. And he finds that black boys in America have lower earnings than white boys in 99% of census tracts in America, even after taking initial parental income into account. Why? They live in neighborhoods that differ in access to opportunity. Black boys do just as well as white boys when they live in neighborhoods with good resources, but those neighborhoods are very rare in these United States. And what these data are telling us, that the racial inequities we see do not reflect culture, do not reflect the failure of having the right work ethic, and they do not even reflect a broken system. What they reflect is a carefully crafted system functioning as planned, successfully implementing social policies, many of which are rooted in racism. They are not accidents or acts of God. Residential segregation illustrates how racism has produced a truly rigged system in the United States. So where do we go from here? We need to create opportunities, communities of opportunity, I like to call them, to minimize, neutralize, and dismantle the systems of racism that have created these inequities in health. And that begins with enriching the quality of neighborhood environments, increasing economic development, improving neighborhood housing and safety. So those are big factors that we have to address if we are going to be serious about dismantling the negative effects of the structures that racism has put in place.
Thank you so much, David. I wonder if I could follow up just with one question in relation to what you just said about racial segregation and residential segregation and the importance of place. So this is a rigged system, but it's rigged by many different players. I mean, there's not one determinant. It's not just availability of mortgages. It's not just discrimination by landlords. It's not just income levels that enable you to pay certain rents and not others. It's multiple factors. So if you were to say how one addresses, this rigged system and how one really tries to drive an alternative which gets us away from this kind of apartheid. I think apartheid is not too strong a word, actually, in a way, for how this system is organized. What would you identify as the kind of key priorities in your view?
It's a great question. Professor Barbara Reskin has written about this, the fact that it's a system. And if we just tinker with one aspect, the system will compensate for that aspect we've tinkered with to maintain, in fact, the status quo. So we really have to think of an exogenous shock that changes the entire system, or if there is some particular place we could intervene that then has ripple effects across the system. I think she identifies, and I think that if we could, in fact, fundamentally address residential segregation and create opportunities in the neighborhood, that could have ripple effects across education, across access to opportunity, in terms of employment, in terms of wealth, in terms of access to home ownership. But we have to understand that tinkering with one aspect of it is not going to have the impact that we would like to see it have.
Thank you. Yeah, that makes perfect sense. So if I may, let me just move on to briefly introduce our second panelist. Dr. Habib Nakhvi is the director of the National Health Service Race and Health Observatory in the UK, an organization that was set up just last year to address the specific health challenges facing people from Black, Asian, and minority ethnic backgrounds. Dr. Nakhvi is a recognized leader in the healthcare policy and strategy development field, and he has advised governments and a range of public sector organizations on health equity issues and policies to advance them. So we're going to kind of home in now really on just narrowly on the health question to kind of continue to address this question of the emergency, in a way, that we're facing in terms of the need for a response. So Habib, if I may, thank you very much for joining this discussion. And what I wanted to ask you is this: the observatory is obviously a recent response to a growing awareness of the enduring and significant impact of racism on Black, Asian, and minority ethnic populations in the UK. But what do you think it has generated so far in terms of new evidence and policy takeaways? How would you assess its contribution? And part two of my question, what do you hope for from the observatory, say, in the next 5 years? In other words, what role do you hope that this compilation of data and this organization of research and evidence that's being generated, what do you hope this will actually contribute to the kind of public sphere discussion and development of policy in the UK and beyond? So over to you.
Great. Thank you very much, Professor, for inviting me today. I agree with my friend and fellow panelist, Professor Williams, around the fact that this is absolutely a global and system-wide challenge that requires a global and system-wide response. And that's what I guess the NHS, the National Health Service in the UK, have been focusing on, particularly over the last period during the pandemic, in order to have a more focused response to this. And I wouldn't call it an emergency, I would call it a level of urgency on this particular area. Because the fact is that we know that there are racial bias and inequalities with regards to access and experience, and of course, therefore, outcomes in relation to health. And across a huge range of different areas, whether that's genetic counselling or artificial intelligence or maternity health. And within the UK, those differences are set against higher levels of disparity or higher incidence of particular diseases, including some of the ones that you will be very familiar with: high levels of diabetes, cardiovascular disease, specific cancers. And of course, what we've seen over the last 20 months or so is the disproportionate impact of a pandemic on our ethnic minority communities and ethnic minority healthcare staff. So there is that level of urgency to focus on this area. And I guess in the UK, the country and our healthcare system should be well positioned to focus on that level of urgency. We've had a long history of migration in our country, in the UK. We therefore have large and growing ethnic minority communities, and we've always had very good investment in healthcare research. However, it can also be argued that at the same time, our responses to ethnic health inequalities and the biases that we see and the disparities that we see historically have been somewhat fragmented, confused, and costly. And whereas specific units, commissions, and think tanks have in the past been set up, they have been set up to carry out, I would say, kind of academic exercises of data collection and focusing on surface level issues without focusing on the causes of the causes around some of the disparities that we see. And therefore the NHS Race and Health Observatory is in a way, a response to that, in that the observatory focuses on three things. Firstly, to bring together evidence and the evidence base and insight. Secondly, to turn that into actionable recommendations for policy change on the ground. And thirdly, to support the healthcare system and policymakers to implement those policies as part of their day-to-day work. And we have begun to do that in an independent way, because we are an independent observatory. And that is a very important point as well, because no longer should organizations be setting their own exam questions and marking their own exam paper on this particular area. So that level of objectivity is exactly what is needed in order to increase the level of trust and confidence in the research and trust and confidence in the recommendations that follow. So some of the things that we've been working on since the beginning of the observatory, which is, I have to say, only a few months old or young, as you may say, but we've certainly established a strong work program that looks at a number of things, really. Some of the deep-seated, deep-rooted issues that we have around the biases and the inequalities and the disparities that we see in the UK, maternity health. And it cannot be the case that today in 2021 in the UK, Black mothers are up to 5 times more likely to die during pregnancy, childbirth, or soon after. Asian women are up to 2 times more likely to die compared to white British women. And of course, we've got the figures and statistics around diabetes and heart disease, overrepresentation of young Black men within the UK mental health system. So, and the list goes on. And so we've been focusing on some of the deep-seated issues, but also being very responsive to emerging matters of the day, where we can, I guess, pull the trigger on things that can have a positive impact on people's lives. And over the last few months, we've been focusing on building the levels of trust and confidence in the COVID-19 vaccine amongst our ethnic minority communities and healthcare staff. We've been focusing on looking at potential racial bias in pulse oximetry. And I'll come back to the kind of the bias issue around that, but it's very much about how research is put together, actioned upon in terms of building devices, and how the bias emerges right from the lack of representation in research, lack of representation in researchers themselves, which then kind of feeds down to the way that services are designed and delivered, as well. And we are focusing on mental health and looking at the type of therapies that are given to the white population compared to the ethnic minority population, and doing a kind of systematic review with very clear policy recommendations for change there. I guess coming on to your second part of the question, Professor, my vision for the observatory is to remove excuses that we've had in the past around taking action that makes a difference. Remove excuses that have led to the inability to look at those causes of the causes in some of the work that has been done in the past. And I started off by talking about kind of this global aspect around race, racism, and disadvantage and bias. And that's absolutely true, because if you have a look at different parts of society, and I'm thinking about the United Kingdom here, whether that's employment, whether that's education, whether that's a justice system, that level of inequality exists and contributes to the stratification that we see within health, but across all aspects of life. We're very lucky in the UK that we have a free, at the point of contact, health service. And I guess the NHS is perhaps the most visible expression of a social contract between people. And we've seen that so vividly over the last 20 months or so during the pandemic. But to be proud of our NHS and to be proud of our healthcare system, we cannot be blind to some of its imperfections. And the stratification that we see within health in terms of access and experience and outcomes is an example of that, that imperfection that we are focusing on now, and not just focusing, I have to say, within our own borders, but globally as well. And with the excellent support and leadership of Professor Williams, we have established an international group with experts on race and health from New Zealand and Australia and South Africa and Guatemala and North America, people that want to focus on identifying some of the common solutions to some of these common challenges that we have with regards to ethnic minorities and racism across the globe. We're very delighted to have the twinning relationship between the Observatory and the CDC in the States on the fringes of the G7 summit earlier this summer. And we will be absolutely focused on bringing together cutting edge research and engagement to focus on this challenging issue going forward.
Thank you very much. That's fascinating. Habib, I wonder if I could also just have one follow-up question for you before we move on to our final panelist. The NHS is often held up as a model, and sitting here in the US, it seems like a absolute shining example of something that one would hope to achieve in a civilized, democratic, rich society. A. B, as you rightly say, the UK has seen, large-scale immigration for centuries, and building on its post-colonial past. So immigrants are not a new aspect, and Black people and minority ethnic people in the UK are not a new aspect of British society. And C, my sense is that residential segregation in the UK is much less pronounced than it is in the US in the way that Professor Williams just described it. So you have these three positive elements. You have, a long established socialized system of healthcare delivery free of charge. You have a long experience of, a diverse, racially diverse and multicultural society. And you have a kind of, rather congested, highly densely populated island where residential segregation is not as dramatic as it is here. And yet, you gave us this very shocking statistic, that 5 times higher rates of maternal mortality among Black women in the UK than whites. So as I asked, what I asked Professor Williams was, how would we think about dealing with residential stratification, which is such a multi-layered phenomenon? In the UK, where you already have some significant advantages, particularly in having a free system of healthcare, what are the primary drivers? I mean, you mentioned some just now. You talked about, access, you talked about experience, you talk about outcomes. So I'm thinking that maybe what you're talking about more is kind of attitudinal issues. There's kind of like lack of trust because there is explicit stigma, discrimination, overt racism that people encounter when they access services they're entitled to. Which is different from saying that you live in a neighborhood where there aren't the right services, for example. So I just wondered if you could say a little bit more about how you see the task of tackling this primary driver, perhaps, of the radical inequity you talk about, which is this kind of set of very deeply entrenched, hostile and racist attitudes and behaviors.
Well, I guess in the UK, I would argue that the differences we see, the racial disparities and the biases we see are perhaps more implicit than explicit. And we do have, I mean, of course, we have those biases which kind of lead to the differences in access and outcomes that I highlighted. And some of those biases include, of course, doctors' assumptions around pain management, by ethnicity. Some of those biases are embedded, deeply embedded within policies and the processes within our healthcare system in the UK. That and those have been around not just for years but for decades. And shifting some of those isn't easy. And of course, as I mentioned before, some of the biases are in the evidence upon which interventions are designed and delivered as well. And the pulse oximetry example that I gave is just one of those examples. And another being which we are beginning to look at is something called the Apgar Scale, which is used in maternity to determine. I mean, one of the things that's looked at within the scale is how healthy a baby is minutes after its birth. And one of the criteria is whether or not the skin color is pink. And that's a scale that's been around since 1952 in the UK. So there are implicit biases there that have been there for some time. And I guess doing more of the same will no longer suffice. And I always say that as a result of the Black Lives Matter movement that was talked about in previous session, but also the pandemic, this has to be a refresh moment rather than a reset moment, because we do not want to go back to some of those practices that have been there previously, but we need to refresh them and to revise them. Some of the things that I think can help here is to amplify the narrative that this is not just the moral, the right thing to do is it's not just a moral case or a legal case. And of course, we've got some very good legislation in the UK around equality and health inequalities. But this is also critically a patient outcomes case, patient safety case. And for organizations, this is a financial case as well. You get this right, organizations will save money. But of course, we're focused on the patient care and the patient outcomes case. There needs to be accountability here, real accountability, and a real focus on getting people to focus and to drive their thinking on this agenda because they want to, and not just because they have to as a result of regulation, as a result of kind of contractual relationships or assurance. And that's a critical bit here, so that people actually understand that tackling racism, tackling disadvantage will benefit them as much as anybody else. And that's kind of a real important bit that we need to kind of think about. Thirdly, engagement. meaningful, sustained engagement with our communities is absolutely right, so that our interventions are fit for purpose. And then finally, but probably most importantly, is leadership. Demonstrable leadership is not just what people or leaders say, but what they actually do, which is absolutely critical as well.
Thank you. That was really a very full answer. So again, it's of course so multifaceted, and this is a very tough set of complex and interlinked issues that you're addressing. So thank you. So I'm now delighted to turn to our third panelist, Professor Sherelle Barber, who is actually a graduate of our school, an excellent advertisement for the work we do pedagogically. She's an assistant professor in epidemiology and biostatistics at Drexel University. And Professor Barber's epidemiological research in a range of settings is framed through the lens of structural racism, which is why she's such an important contributor to this discussion. But she uses interdisciplinary tools to inform the work that she does, and has a range of complex and sophisticated epidemiological methods that she's deployed in her research. And I think it's a really good segue to the two panelists that we've had so far. So Sherelle, you have used these complex research methodologies to examine ways in which exactly the kind of big constructs that we've been talking about, place, race, and health, intersect to directly impact key aspects of health, such as, and I think Professor Nakhvi just mentioned one of them, cardiovascular risk and disease, and you've looked at that specifically, both in the US and in Brazil. So I wondered if I could start off by asking you, how does racism, in your view, become embodied in the neighborhoods in which you've worked? How would you describe the kind of embodiment of racist practice? And then, of course, we'd love to hear a little bit about what you think can be done about it. So first of all, just describe to us how racism manifests itself, both in the US and in the Brazilian communities that you've studied. And then secondly, give us your thoughts a little bit about kind of ways forward. Thank you.
Absolutely. Thank you so much. And it's been actually an honor to be back here at Harvard, the School of Public Health, to be on this panel with Dr. David Williams, who I was in his class just, years ago. And so it's just really exciting. I actually do want to share some slides. And if you don't mind, I want to actually put that question in some context and really focus on Brazil, because I do think it is a very important context for these conversations. And so talk a little bit, and before I even get started, I actually want to acknowledge that there's already really powerful work happening in Brazil, particularly that has been amplified during the COVID-19 pandemic. A group of Afro-Brazilian scholars and activists who formed the working group, the Racism Working Group, as a part of the Brazilian Association of Collective Health, who are doing really powerful work in this area that I think is really important, really relevant for this conversation. And so this work is really kind of framed, and I want to frame it kind of in some of the just very key data points about Brazil. One, that it's rooted in the infamous legacy of slavery, and in fact, Portugal enslaved over 10 times more West and Central Africans during its 300 years history in the country. It has the largest Afro-descendant population outside the continent of Africa. Over 50% of the population in Brazil is Afro-descendant. And despite narratives of being a quote unquote racial democracy, has a history and legacy of racism and oppression that has perpetuated and maintained the marginalized racial status of individuals of visible African descent. This is really, really critical. And if you put that into the context of Latin America, we know that Afro-descendants not only reside in Brazil, but also in other countries. And in fact, data from 2020 show that about 20% of Latin America is Afro-descendant. And most of these Afro-descendants reside in urban areas. And so the health impact of urbanicity and racism and segregation and how that plays out in Brazil and other Latin American countries is really critical as we have these conversations. And I also just want to point out a scholar, Leila Gonzalez, who was an Afro-Brazilian feminist anthropologist and activist, who was one of the major leaders of the Black movement beginning in the 1970s. She talks about segregation in this way that really, I think, really paints a picture of what it is, not only back then in the 70s, but also now. She says, from the colonial period to the present day, one perceives an evident separation as to the physical space occupied by dominators and dominated. The natural place of the dominant white group are healthy dwellings located in the most beautiful places of the city or the countryside and duly protected by different forms of policing, ranging from overseers, skippers, et cetera, to the formally formed police. From the big house to the beautiful buildings and homes of today, the criterion has been the same. On the other hand, the natural place of the Negro is the opposite, of course. From the slave quarters to the favelas, the criterion has been the same, the racial division of space. In the case of the dominated group, what is verified are entire families huddled in cubicles whose hygiene and health conditions are most precarious. In addition, there's also a police presence here, only that it is not to protect, but to repress, to violate and to frighten. That is why it is understood that the other natural place of the Negro are prisons. The systematic police repression, given its racist nature, has as its objective the establishment of submission. Now, this quote for me has been so resonant as in the last year, particularly as we've seen the COVID-19 ravish Black communities in Brazil, with higher rates of COVID-19 mortality and morbidity among Black Brazilians compared to white Brazilians, at the same time juxtaposed to horrific examples of state-sanctioned violence. And the most recent, actually, earlier this year, when there was a massacre in the Jacazinho favela in Rio de Janeiro, Brazil, in which 200 police officers in armed vehicles raided a neighborhood, a favela in Rio, and killed 27 individuals in that massacre, right? So again, you have the segregation that is longstanding within the context of Brazil, the conditions, housing, economic opportunities, and otherwise that calls for things like COVID-19 and other health outcomes to be more pronounced in these areas, and the presence of state-sanctioned violence that has been a mainstay in Brazilian cities for many, many decades. And so all that coming together really produces what I consider to be the embodiment of racism, that these places produce adverse conditions that literally show up and manifest, whether it is in cardiometabolic risk factors such as hypertension and diabetes or obesity or other health outcomes. And in an article that I led that was published in Social Science and Medicine in 2018, we explored this intersection, looking at segregation, thinking about how this plays out for different racial groups within Brazil, finding that Blacks residing in higher segregated neighborhoods had higher levels of hypertension, higher levels of diabetes, and also in follow-up analysis also showing that Black women in Brazil had higher levels of obesity and adiposity. And we've also done produced data that looks at diabetes management, again, same patterns, and are beginning to look at how metropolitan level segregation shapes racial inequities in cardiometabolic mortality across cities in Brazil. So this is data that we've been producing, and I think it's really critical, again, in a context in which this research on racism is not new, but it hasn't been supported, and it's really exciting to kind of continue to move this work forward. I think that this research has also, I want to point out, because as we're having these conversations about race, racialization, and racism, it's important to understand the nuance that's embedded in Brazil, that the racial categorization is very different than what we might see here in the US. And that also has implications for how we're understanding how these mechanisms operate. So for example, we looked at descriptive statistics of our segregation measure by categories of race: Black, brown, which is Pardo or mixed race, and white in Brazil, and found that the distribution of segregation was different depending on the racial composition of the city in which it was embedded. So for example, in Salvador, Bahia, which is 20% white, 80% Black and mixed race, we found that there was a more distinct gradient between Black and Brown residents when it came to residential segregation in our sample. However, when we looked at a place like Porto Alegre that was 80% white, we saw that Black and Brown individuals had similar levels of segregation compared to whites. So you have these regional variations in how racism is operating. You also have changes in how people self-identify race over their life course. And in fact, there have been certain points in history that have pushed for individuals to identify as Black or identify in a certain way because of some of the social movements that have happened in Brazil. So race isn't constant, and we have to really understand that complexity if we're going to understand how it plays out, how it manifests and produces the racial inequities that we see in health outcomes. And so what's the way forward? I actually think that my inspiration comes from a woman by the name of Marielle Franco, who, as we talk about embodied racism, we also have to talk about embodied resistance, that these systems and structures that produce these harmful and painful effects in our communities also produce powerful movements against the systems and structures. And I actually think that's where some of the solutions lie in terms of how we're actually going to make a difference. One of the fascinating things about Marielle Franco's life is that she was trained in sociology. She was trained in public administration. She was a local city councilor that used her lived experience as a Black queer woman born in the favela and coupled with her academic kind of expertise in these areas to really drive for the kinds of policies that would produce thriving communities in Brazil, that would value the bodies of Blacks and other marginalized groups in Brazil. And I think that's the energy we have to tap into, especially given this moment in history where we've seen how movements really are moving the conversation, helping us to move the needle and think really radically about the world that we need to create for everyone. So I'll stop there and join with additional folks from the panel.
Thank you so much. Well, those were wonderful comments, and I actually would have follow-up questions for you too, Cheryl, but we are really marching against time here. So, but I'm so glad you talked about Brazil, because actually one of the questions we had from the audience was how things would be different in tackling racism in healthcare and public health in a low and middle income country. And I think you showed very interestingly how, of course, specificity is always critical, and how even within a country, of course, massive like Brazil, you have to look at regional and local specificities in developing your anti-racist strategy. So perhaps I can just raise one question from the audience, and it's for you, Professor Williams, from Deborah Stroman. And her question is, to what degree, if any, must the government intervene to create these necessary opportunity communities, considering that grassroots efforts often lack the resources and what do you think? And could you say a little bit more about how the government should intervene to, I presume, address segregation and beyond that, create opportunities for communities to access better healthcare and other services? So what would you identify as the key priorities for government?
Well, I mean, we are all citizens of a particular society. We can influence what a government does. Martin Luther King said that the arc of the universe is long, but bends towards justice. But Barack Obama commented that it doesn't bend on its own. So we can be active in bending that arc and demanding that the government stand up and do things that, in fact, it should do. There are a number of papers written looking at the impact of the civil rights movement on, for example, that in shaping government policies and shaping legislation that have had an impact. Now, have they gone far enough? No. And so there is power I like the fact that Cheryl talked about the resistance, and we have to celebrate that, and we have to celebrate the power of people movements that can prod the government to do things that it wouldn't do on its own, but it will take decided action. And finally, I would say, I like to sometimes talk about the need for a Marshall Plan, the way the United States invested in a Marshall Plan to help rebuild Europe after the Second World War. We need a Marshall Plan for disadvantaged communities in the United States. And all of us need to raise our voice to call for the kinds of investments, by the way, that would, if we enhance the productive capacity of all individuals in this country, we strengthen the US economy. And there's research that is showing how the racism in this society is costing our economy billions of dollars a year. So yes, it is in our collective interest, but it's not going to happen on its own. And the government is not going to wake up one morning and do it if there isn't pressure and mobilization to demand these changes.
Thank you. Absolutely. So combining the top down with the bottom up with the need for these grassroots movements. Dr. Nakhvi, I wonder if you could also address that question. So, the relationship between what governments and policymakers, who your research is targeting, what they can do and what kind of grassroots and citizen and presumably NHS consumer movements can also contribute. Could you say a little bit about that in the UK context, and how you see that combo of the role of government with grassroots movements?
It certainly is a thing about social movement around this. I totally agree with that. It's also about individuals, organizations, and governments making sure that their moral compass is pointing in the right direction on some of these topics. But it's also at an individual level and as society as a whole, because no longer should this agenda be the burden of those that are most affected by it, and having allies that actually stand not just alongside you, but sometimes in front of you as well, is absolutely critical. And sharing, having that collective voice around this agenda, amplifying the narrative as to the importance of this agenda for everyone is absolutely critical. And comms or communications and media have a huge role to play in that. We saw it during the early part of the vaccination program in the UK, where some groups were being demonized for the lack of uptake and by the media, and so we need all parts of society to come together on this particular issue. And I totally agree with Professor Williams that we need that social movement, and we need that actual drive for people, organizations, and institutions to focus on this agenda.
Thank you. And finally, Professor Barber, if I could just ask you, continuing this line of thought and building on one of the questions that we've received about the importance of participatory mechanisms. So one of our listeners asked whether the participative budget was included when Porto Alegre was examined, and is this was a kind of community participatory kind of engagement part of maybe what resulted in a different scenario in the Porto Alegre's context from the one in Bahia that you just referred to?
No, actually, no. All of this data was secondary data analysis, so we weren't able to really explore that. But I just want to just second everything that has been said about the idea of movement. And some of us, even last year, joined with the Poor People's Campaign, for example, Dr. Bassett, the Health and here, Natalia Linos, and saw the power of why it's important to really kind of go alongside movements that actually have the critical analysis of why these issues persist, but also the radical imagination of what we can do when we come together collectively. So I just want to echo that. I think it is a part of what we have to be talking about in these conversations if we're really going to dismantle systems, structures, and move the health of populations forward.
Thank you so much. Unfortunately, I have to close this panel. We have so many more issues we could discuss, but thank you for fascinating insights, for presenting us with both the urgency but also the complexity of moving forward in this critical area of racism and its impacts on public health. So thank you all three very much for joining us today. And I'm going to hand it back to Professor Bassett.
Thank you.
Thank you.
Great. Well, I really want to thank everyone for just a wonderful conversation. And it's my great pleasure to hand over the introductions for the next panel to Dr. Monique Jimenez, who is also joining us at FXB as part of the our renewed interest in and expanded interest in structural racism. I don't have time to say more about you, Monique, but over to you and to introduce the next panel.
Great, thank you so much. Thank you, everyone. Thank you, Dr. Bassett, and to the Center for this opportunity. I want to thank everybody for being here with us for this last portion of our symposium. And this panel is titled Anti-Racism in Public Health Policies and Practices in the US. So we're going to examine this by asking, how do we define anti-racism in public health? How do we engage in anti-racist policies through practice and education? And how do we work to fundamentally share and shift power structures? So each of these concepts is going to be interrogated through the lens of data. And we'll consider the role and responsibility of public health in shaping issues of data transparency, in data capacity, interpretation, and ownership. So we're really blessed today to have the opportunity to address these critical issues with our three esteemed panelists, and I'll introduce them very briefly, but just so that everyone knows, their full bios have been placed in the chat. So first we have Dr. Christina H. Fuller. She's an associate professor of environmental health in the Department of Population Health Sciences of Georgia State University School of Public Health. Thank you for being with us, Dr. Fuller. We also have Dr. Nancy Krieger, who is professor of social epidemiology and American Cancer Society clinical research professor in the Department of Social and Behavioral Sciences here at the Harvard Chan School, and director of the Interdisciplinary Concentration on Women, Gender, and Health. Thank you for being with us, Dr. Krieger. And we also have Dr. Letha Maybank. She is the Chief Health Equity Officer and Senior Vice President for the American Medical Association and leads the Center for Health Equity. So earlier today, we've discussed and we've heard from Professor Hammonds about the deeply racist history of public health in the US. And similarly, Professor Mohammed spoke about the intentionality and structurally violent responses to public health leveraged against Black Americans and other historically marginalized and stigmatized populations. Understanding that history is really fundamental to thinking about how we can dismantle these entrenched systems of oppression through anti-racist policies. So I'd like to ask each of you if you can share what anti-racism means to your respective areas of work. So Dr. Fuller, let's start with you. Could you discuss the overarching definition of environmental racism and how it fundamentally interconnects all other aspects of the lived experience over both time and space?
Yes, definitely. That is a very big question, but I will do my best. I mean, I think it's important to acknowledge that environmental justice, that's the area that I work in, that I base my work in as I look at exposures and also health outcomes, is that EJ is a grassroots movement. So there's no necessarily one specific definition for environmental racism, but I'm going to give you one that's along the lines of Dr. Benjamin Chavez, who coined the term environmental racism some years ago in the late 1970s or early 1980s in Warren County, North Carolina, where community members were fighting against a hazardous waste landfill in their community, in this mostly rural and Black and poor county of North Carolina. So environmental racism is directing environmental hazards to specific communities because of their race, also discrimination in environmental policy making, and excluding people of color from leadership. So if you look at research around race and environmental health and exposures, race is the most important predictor of environmental hazards in the United States, and income and poverty is the second most important. So race is definitely the deciding factor for the location of lots of hazardous waste sites in the United States. However, we also acknowledge that race and poverty and class are also closely but not exclusively associated. And now many people consider their environment to include not only the physical parameters, but I have a more broad definition in terms of chemical exposures and urban landscapes, of course, because they determine many exposures to chemicals, but also social factors such as poverty, psychosocial stressors, which can increase your vulnerability to environmental exposures, and also culture, which has implications on power and control to be able to make your own definitions. And there is interaction between these factors across the life course, and these experiences, pressures, and conditions are racialized, and as a result, their impacts differ by community and identity as well. So in terms of anti-racism, it's going to be those beliefs, practices, and policies and actions that promote environmental justice. And this is based first on the health of Earth and participation in environmental planning and self-determination for communities, freedom from hazardous exposures, and resulting poor health, as well as the education of young people too. To understanding about environmental stewardship.
Thank you so much, Dr. Fuller. And that really leads us now to Dr. Krieger. Can you discuss a little bit more about this social aspect of these social categories and the critical importance of grounding the use of racialized data in that historical and social context?
Sure. Thank you very much. Very glad to be part of this whole symposium and this particular session and with these panelists. And I think that the first session really spoke some to the history. In the US, people that are using contemporary racialized data are typically drawing on data that have a real institutional history to them, fundamentally through the US Census. And you have to ask, why were people counted? Counting has always been about political power. It's been about apportionment of resources. It's been about political representation. That's why there are the fights that are happening now about gerrymandering, about voter suppression, and all the rest. It's consequential. The categories were first set up in order to distinguish between people who were free, who were enslaved, and then among indigenous populations, those who were considered to be Indians, not taxed, as in not under US colonial rule, and then those who actually were. And those categories were used fundamentally at the beginning to discriminate. They were also used in conjunction with the kinds of occupational data that were introduced in the second census around who, again, with the whites even who could vote, you had to have property. It wasn't just the unproperty whites. So those data have always been tied to points of view of initially how to discriminate, how to ensure who had the rights to have ownership of whom, who had control over the labor of whom, who could get their wealth from using the labor of others in ways that were not fair and equal. But that has changed at the same time because of the social movements that were also discussed, starting particularly in the US. You see a pushback starting in the 20th century and before of using the racialized data to actually try to show the impact of discrimination, as opposed to saying it's about innate properties of people that justify discrimination. So there's been this pushback, and legally what happened was you really saw a move in the civil rights movement to using data around race as defined by the census to point to the existence of discrimination, which could be then opposed. Then there's reactionary pushback against that, trying to get rid of the possibilities of showing evidence of harm using what's called quote unquote statistical discrimination. So but I think a key point that stands out if you're going to take an anti-racist standpoint is that it is never sufficient to only use data on the racialized categories that are available in the census without having ancillary data built into that. Whether that's about, if you're interviewing individuals, experiences of what kinds of racism they have experienced in different kinds of settings, at work, in the street, in many different, in voting, in all kinds of, in healthcare, et cetera, but also the conditions of the neighborhoods in which people live, the communities in which they live, and that there's a tendency in the US to be fixated on the individual levels and not bring in enough the contextual and policy levels. So it makes a huge difference if you're living in a place, we've had the discussion already about impacts of segregation, but you also have to look at what's behind that, the historical redlining. How do you start to bring in those data that actually show the structural drivers, the interest, who is benefiting from the kinds of discrimination that then play out in workplaces, in environments, as just discussed by Christina Fuller, in all the rest. So these are not data that ever stand on their own 2 feet by themselves. And it's really important to understand the institutions of the census, who is controlling the Office of Management and Budget, why the categories are what they are, what they mean legally. You can't just get rid of them and say you prefer other terminology. There's actually law that goes with many of these different terms if you're trying to have anti-discrimination, anti-racist standpoints. So I think it's really important to bring these 2 pieces together, which is to understand the categories are socially made. Doesn't mean they're just made up, they're made. You have to ask why they're made, by whom, who had power, who contested that, what are the continued suits that go on around the census data, why it's so important around both political representation and allocation of resources. So many federal programs depend on the counts in the census, including by race, ethnicity, around the allocation of resources. So it's really crucial to understand these categories historically, understand whose interests they've served, understand they've served different groups' interests, and that they are in contested categories and their use is contested. And that's part of what's necessary for actually critically analyzing health inequities and trying to do something about the sources that are driving it.
Mm-hmm. Thank you so much. It provides all of this provides a lot of context for also movement that we've seen within academic medicine. And so in a lot of this very individual level approach in academic medicine has rested for centuries on this biologic race ideology, which we know to be false. Dr. Maybank, can you talk to us a little bit about that pushback against the use of race in that way and contextualizing race as a social construct and understanding the historical framework?
Yes, thanks. And thanks for inviting me to be on this panel today. Excuse me, I'm losing my voice just a little bit, so please, I apologize. The reality is, medicine has been, I think, a little slow, as folks would probably agree with, to really listen and engage, in this way around acknowledging of race being a biological, race being a social construct and not a biological construct. And the realities is that white supremacy and patriarchy, really fuels racism, as we all know, and other forms of suppression. And it's really deeply rooted and core to medicine's foundations. And so at times I feel, and I'm sure others feel, that this is potentially an uphill battle. Medicine, especially physicians, still lack consensus and guidance on the use of race, even with clear knowledge and evidence that race is not biological, and the growing evidence of the gross harms and potential harms of using race-based medicine or using race as a proxy for biology or genetics and ancestry, whether it's in medical education or clinical practice. Notably, clinical algorithms used by thousands of clinicians daily across this country and beyond, many of them actually adjust or correct for race and ethnicity still. There's currently a movement to shift that, but we're at the very beginning of that. And, these algorithms that use corrections in this way are, they set guidelines and treatment plans. And it really demonstrates how clearly racism is still very much embedded into medical practice, and embedded in a way where there really isn't much evidence or footing as to why this correction, has happened or is happening in the first place, outside of the realities of racism itself and the desires to exclude, and the realities of our hierarchy of human value based on skin color, with white being on top. And so, for medicine, anti-racism practice really, will, to me, revolve around ending the use of race-based clinical decision-making models, as well as calculators, definitely ending, segregated healthcare that was already elevated, ensuring that we have national standards around health equity and racial justice standards and benchmarks, Also ensuring that our AI is, free from harmful and biased algorithms. Mentioned before when talking about environmental racism, the realities of exclusion are tremendous, and oppression within physician education, training, and hiring, as well as promotion. And so anti-racism work really speaks to eliminating that. And it also speaks to how we ensure equity within the context of innovation, from jumping from public health to healthcare. Innovation from the technology point of view is really highly valued and means something very specific, very much rooted and aligned with many of our capitalist ways in this country, which excludes many people, as we all know. And so in order to have equity and anti-racism practice, we have to do a lot to ensure, to support that there are more folks of color who have opportunities to create, to design, who have access to capital in ways that they have not and do not at this time. And critical, as it was already mentioned, in order to do anti-racism work in medicine is acknowledging and repairing past harms that were committed by institutions. And AMA, longstanding organization, 1847, very well known for many of the harms that the institution has put forward, such as the exclusion of Black physicians for almost 100 years, but also putting forward tremendous opportunities that transformed medical education, such as the Flexner Report of 1910, that actually recommended the closure of 5 of the 7 Black med schools, but also transformed what was taught in med school. So really transitioned medical education to talking about the basic and clinical science, away from the social context, away from social sciences that we know are very critical to understanding the full context of health. And that has had tremendous impact and has created, I think, tremendous harm. And we have to do a better account of that and understand those harms and do something about that in the future.
Thank you. And I think, from what we just discussed, when we are considering how public health can really engage in both dismantling racist policies and supporting and directing anti-racist policies and practices, this thread of data is consistent throughout, right? Who has the data, and how do we use the data? And so to direct those policies. And so I wonder if we could use some touchstone examples to motivate some of this discussion about what has gone wrong and maybe places where we can shift the course. And so Dr. Krieger, in your work with respect to the COVID pandemic, we've seen, and in many spaces, that data opacity is a very subversive mechanism of structural violence. Can you talk to us a little bit about how data opacity has played in impeding our ability of the full scope and the full impact of COVID-19 in the US, and what has changed more recently?
Absolutely, and COVID provides a very striking example of the politics of public health data deeply embedded in issues of racism and also what anti-racist pushback can do. So if you look at the start of the COVID-19 pandemic under the prior administration, at the very beginning, there was not reporting by race ethnicity, and it took public activism, and then the politicians followed up on that to yell and scream, like, where are the racial ethnic data? And this was shocking because virtually all health data in the US are racialized. So how come this wasn't? And what's important to say is that if you look at the CDC website now compared to the CDC website during the prior administration, the health equity components and the health equity page and the health equity data available, they're not perfect, but they are a lot better, which makes it very clear that there was serious political interference as opposed to a lack of technical capacity to get the kinds of data up that need to be looked at. However, that said, the US, and this is something that Evelyn Hammond spoke about earlier in her very beginning, the systems of reporting of data in this country are very, very fractured, and they reflect the fracturing that was built into this country from the get in the way that it was set up as a republic, in the way of the different kinds of state roles. And what that's meant is that states report data to CDC, and if states do a lousy job, the CDC doesn't get good data. And that plays out in the COVID data still. So that, for example, if you look at the current data, in terms of what the missingness is. And this is, again, just about the race ethnicity, because I want to say a quick question then about linking that to other kinds of data. This is better than it was, but right now still cases for COVID are missing 40% at the national level, their data on race ethnicity, versus if you look at age or sex for them by the conventional characteristics, they're only missing 1.4% and 1.4%. If you look at deaths are data that we have all the time in the US, because obviously people are always dying, and the mortality records always have race ethnicity. This is not a new form. Like COVID cases was a new form, but the form very clearly had race ethnicity in it that you're supposed to tick the boxes. We still have 20% of deaths at the national level, if you look at the most recent data, missing data on race ethnicity compared to 0.1 missing for data on age and 0.3% missing data on quote unquote sex. And if you look at the vaccination data, we have currently, right now, as of August 30th, the statistics up there, 37% of cases are missing racial ethnic data compared to only 8% missing either age and 8% missing sex. And what this also means is there are gross discrepancies in the data that you can find available at CDC on what's going on around vaccination. Because if you look at the data that's on the percent of population that's vaccinated by race ethnicity, it's not counting and can't include any of the people who didn't have their race ethnicity recorded. So you end up with all kinds of undercounts and distortions of the data, which preclude really understanding what's going on better. Whereas if you look at something like the household pulse survey that the US Census set up, which was, but it's not at a granular level. It's a state, and it also goes to the 15 largest municipalities in the U.S. You can get data that are self-report, granted, but that are much better, that are more inclusive, that are not missing these data. So the other part that's critical about what happens if you use a household pulse survey to show again what could be done with government data that is capable, feasible, actually happening right now data, is that you have much better economic measures that are absolutely they're right there. You can just do crosstabs in a second. You have data on poverty, you have data on food insecurity. You can start to show the contours of what the economic shock of the pandemic has been, how it's been racialized, and what that has also meant for health status and also for what's going on around vaccination. So the point is there is technical capacity, there is also political fragmentation, and there are state governments that are literally not reporting their data to CDC, as well as making a hash of collecting and enforcing adequate collection of racial ethnic data in relation to COVID. So these are fixable problems. There's plenty more I could go on about, but time is short. But I want to make it really clear that these become political judgments, and what's been really critical in getting the pushback to actually get the data necessary have been movement voices speaking up, have been public health and medical professionals speaking up, have been people who have said, we're trying to do a better job here, and we can't if don't have these data, and these data, they're not pie in the sky, they really do exist.
Thank you so much. I think it highlights the importance of foundational epidemiologic measures, right? We can't understand the full scope of the problem when we're not collecting the data, and those things are intentional. And I also appreciate highlighting the role that we and our responsibility to voice those concerns, to move the needle and to make that change. And Dr. Maybank, you were speaking about the clinical algorithms that use these quote unquote race adjustments, and these have had incredible harm for Black Americans. The estimated glomerular filtration rate algorithm is probably the most widely discussed, although there are many, many others. And I wonder whether you could speak a little bit about the responsibility of medicine, because some of this change in the pushback against the algorithms has come from our emerging physicians, right? And is a very grassroots movement as well. I think you're on mute, Dr. Maybank. Thank you.
There we go. Absolutely. Thank you. I think there are several things that propelled the AMA specifically, and AMA has influence, whether folks like the AMA or not, it still has influence within the context in this sphere of medicine. One was the public murder of George Floyd, which moved and propelled many folks across this country. Two, you already mentioned kind of the organizing and really the strong and powerful voice of our young physicians, our med students within the AMA that have voiced and courageously voiced in an environment that is, representative, very similar to, the United States of America, which has the South, which many folks know have risen up, at certain times of this year to prevent some of the actions that we've been doing at AMA. But the young people, I just want to say it, have been absolutely there. And then there's some groundbreaking work and publications that happened that have really propelled our work forward. Back in August of 2020, there was a publication in the New England Journal of Medicine called Hidden in Plain Sight, reconsidering the use of race correction in clinical algorithms. And it was done also by a young physician, Darcy Levias, who at Mass General and others at Mass General and Harvard Med School more than a year ago, just really highlighting 13 clinical algorithms that correct for race and race and ethnicity and the potential harms. And usually, oftentimes it's lowering the risk of disease specifically for Black patients and setting the context for having delayed treatment and therefore further inequities. And as you mentioned, glomerular filtration rate is one of the most that's most widely known. But when they looked back again to see kind of what was the reason why they were using these algorithms, there really was no great explanation to that by the developers or, as to why there was the differences. And they were really rooted on many of the historical false notions and racist notions, again, of a hierarchy of human value. For glomerular filtration rate, it was based on believing that Blacks have greater muscle mass. And so those types of beliefs, and we have recent studies that really still demonstrate that many are still holding on to those beliefs throughout the field of medicine. And so there's a lot of work that we have to do in terms of educating and how we educate our medical trainees in what they know and what they have learned throughout their entire lifetime and how we work to really deconstruct that. There is also action that has happened on the federal level from our Ways and Means Committee, asking and holding accountable, or at least attempting to hold accountable to many medical professional societies about the use of clinical algorithms. Many of them are responsible for, developing them and putting them forward. And really what was found is that there's just such a variety of how these organizations really understand the use of these algorithms, understand definitions around race and ethnicity, standardization around race and ethnicity. And there's a strong desire that really came out, and all these reports are actually public online from the different associations. But what really came out is that they really want to have more collaboration around it, work with others and not be in silo. But they also want to have greater transparency on the part of how these algorithms are being developed and really have guidelines and opportunities, again, for medical education that have race and racism education incorporated into it, and establish and apply anti-racist practices and policies throughout the life cycle of clinical algorithm, and from conception to implementation into practice. And so there isn't right now a clear mechanism of how that is going to all move forward and accountability that should happen. But there has been movement. Since past April, the National Kidney Foundation and the American Society of Nephrology, they have a task force. They released an interim report saying that race modifiers should not be used in equations to estimate kidney functions. And there should be a substitute, and they'll have a final report with that substitute. But I think that the key point of that, and there was a lot of kind of, we're talking about, I think, movement building in the prior conversation. These happenings aren't random. There's lots of organizing inside and out. Nancy knows this. I reached out to Nancy, several times, and Dr. Bassett over the year as well, to think through the how and the who to help propel, this type of movement forward, because it doesn't just happen, as we all know. And so for us, as in the American Medical Association last November, we did release 3 policies that were specifically around anti-racism. One was, around racial essentialism in medicine and removing that racism as a public health threat, and then the elimination of race as a proxy for ancestry, genetics, and biology. And it was fascinating because, there was a debate on the floor about this with the House of Medicine. And I remember I thought the one that was going to get the most contention was going to be around the elimination of race as a proxy for ancestry, genetics, and biology. That to me is the more powerful one. But it was really racism as a public health threat, because I think that was so clearly understood by folks just because the language of it, but many folks didn't know what it meant to say elimination of race as a proxy for ancestry and genetics. So, I think overwhelmingly these policies did push forward, but they didn't get as much debate, which is great. But it also speaks to the lack of really knowledge and understanding within the medical community around all of this. And then the critical importance of, again, how do we focus and evolve and kind of revolutionize and transform medical education, do something similar, to the Flexner report of 1910 for whatever needs to happen this year, this year or the next coming years, to really change the mindset, the culture of medicine. I think really has to, be sustained with the activism that's happening. It can be sustained, the opportunity with the activism that is happening with the young physicians and trainings that are coming up now.
Thank you so much. And I think this is a perfect place for us to, since you've given us this understanding of movement within medical education, what do we understand about movement in this space within public health education more broadly? And, essentially, how do we train our next generation, and also how do we retrain our current public health workforce to use anti-racist frameworks and to really interrogate data as has been outlined, and the policies that we have in place, rather than just taking them as fact, and the clinical practices, as Dr. Maybank has reflected on. And how do we essentially move anti-racist education out of the extracurricular? How do we make it core and central for everyone? So I might pose that first to Dr. Fuller, using your framework that you spoke about before with respect to environmental justice.
Yeah, so I think that's a really important question, and there's several ways to go about it. With accreditation guidelines for schools and colleges of public health, environmental health is no longer a mandatory criteria, but environmental health is really important and a good foundation for all public health practitioners to have, because the environment is not just regulated, as I said before, to chemical exposures in this particular place. Example is COVID-19. So COVID is an aerosol, and you have to understand it as being an aerosol, and that's how it's transmitted. So you need to look at the indoor air quality to really figure out how we're going to protect ourselves and stop transmission. And it took a while for that to really be acknowledged, by practitioners and doctors, public health scientists. And so it really needs to be included in the classwork that students are going through. And a part of that also is experiential learning as well, to make sure that there's connections between what students are learning in the classrooms and then seeing how they can put that into practice. In terms of environmental justice, there's the similar, it's very important to understand the historical factors, with Dr. Hammonds and people on the first panel were talking about. None of these conditions are natural, just like we're talking about with, different races having different characteristics. None of that is natural determination. It has been specific. I do a lot of work on near roadway air pollution, especially highways. The Federal Highway Administration placed our federal highway system intentionally to destroy vibrant, economically viable Black communities. It was not straight lines. It was specifically to do that. Housing, in terms of redlining. So redlining, having the different categories of putting Black and other people of color in those red areas to not have investment, encourage the siting of polluting facilities there. And that is the structure that has created these environmental injustices that we see now. And we also have to pay attention to current conditions and then how those are going to change into the future. So making sure that you have exposure science, environmental epidemiology really included, and understanding the interactions between the social and the environmental is very important in terms of training of public health practitioners and also doctors as well, because it's not just the individual choices. Individual choices are restricted based on those larger area level factors.
Thank you. Dr. Krieger, I know you have spent many, many years working on addressing the education of public health professionals around these issues. And I'm sure that you have faced many challenges in doing that. Do you have some other thoughts for us about how to implement this wider education of our public health force?
Sure. First, I'll say something in a slightly different role that I have as one of the co-founders and chairs of the Spirit of 1848 caucus of the American Public Health Association. And since we were founded back in the mid-90s, one of our committees has always been about progressive pedagogy. And what's been so encouraging, particularly in the last 3 years, is the number of submissions to that for that session has soared, particularly with regard to people trying to fix education around bringing in anti-racist perspectives in medicine, in nursing, and in public health, and calling for real interdisciplinary work. So it's just really encouraging. And some of these are student-initiated, student-led courses. This speaks what Dr. Maybank was saying earlier about, the younger generation stepping up. So it's really heartening to me because when, it used to be almost like, is anybody teaching this out there besides a very small number, to all of a sudden there's this like, you can just feel it and you can see it and you can see it reflected in the literature. So I'm very, very encouraged by that because people are stepping up to start changing what is taught. For me personally, it's really critical to be teaching and grounded in the history of public health and social justice as well, bringing in these ideas from the get in the core course that's required for all of now the population health science PhD students that are at our school, which cuts across 5 departments, including among others, environmental health. That the history, politics, and public health about theories of disease distribution absolutely teaches about the histories of race data, of racialization, of settler colonialism, of enslavement, of who's benefiting from what these systems are, as opposed to only having the focus on the people who are most harmed by what these systems are, because that harm, as you also just Dr. Fuller pointed out, is deliberate. And so it's possible to teach this, and it's necessary to teach this, and it's obviously not fun material in the sense that it's not, showing how much preventable suffering has been inflicted is a serious matter, but it's a necessary matter. There's no literally whitewashing of this history, but throughout it's also teaching who has stood up in each and every moment to say there's another way to do this, there's another way to think about this. So class last week, for example, had both the rise of scientific racism in medicine, but also the abolitionist physicians who were opposing it and introducing students to, among others, the work of Dr. James McTune Smith, who was the first medically credentialed Black physician in the United States. And that these arguments about it's racism, not race, easily can be put in the literature before, minimally to the 1830s, if not before. And so giving that historical foundation really matters. It lets students see that they're in a trajectory and a history. They can help move that history. Or, it also shows this class this coming week is, among other things, on eugenics. The history doesn't always just go in a nice direction. And the negative eugenics were quite horrific. And many people don't know that history. So that's part of it. But the other part is then saying, it's not enough to have a critique. It's not enough to have a historical framing. If you're going to be a practicing public health person, you have to know how to work with the data. So you have to understand what the census categories are. They give you your denominators. They also often inform what those rules are, what the health data actually even look like. But you have to go beyond, and this is the crucial part, which I think today's symposium is so important for. You can't just focus on the individual level measures. They're important, but they're not sufficient. If you do not bring in the contextual measures around workplace conditions, around where work is, around environmental conditions, around what the policies are, around what the levels of political leadership are. It's not accidental if you look at the COVID data right now, and you're looking at where deaths are skyrocketing and ICUs are crashing out, that the strongest predictor, we've been doing this in our team, looking at it, are the political predictors. They're not the economic predictors, and they're not the racial ethnic composition predictors. Where you have a trifecta in terms of who is in charge, meaning the governor and both parts of the state government are basically at this point, to be very blunt, Republican-led and not conducive towards actually following public health rules that would save people's lives. You have, guess what, crashed out ICUs, sending patients to other states that are adjoining, and really bad rates. And so I think that this is also showing that you have to think about the data in a societal and political as well as ecological context. That's the whole point for me about the framing that I have around embodying and justice, embodying equity. Where does what and who is driving it? You can't just look at who's harmed. You have to ask who's driving this, how do they benefit? There's an important book by Heather McGee, which is about the sum of us, saying that ultimately most people are harmed, but what fractures the alliances that bring people together? In the US, racism has been a huge one that has fractured the alliances that could bring people together to have a more equitable society and more sustainable society that's not premised about having a very tiny elite in charge.
Thank you so much for that, and that leads us into, I wish we had more time to discuss this more, this issue of power sharing and power shifts fundamentally, right? And we'll use a question from the audience just to close out, which is how the question from the audience member was, how do we convince those individuals that are in positions of power, that are holding the data, holding the access, holding the control, and how do we move a paradigm away from that to, quite frankly, empower, as Dr. Barber said earlier, to the critical importance of centering on the margins and using communities to impact change through radical imagination. Are there any closing thoughts?
I have some closing thoughts about that.
Thank you.
We definitely need to have changes within academia and medicine, nursing, to understand what some of the underlying biases are. And like Dr. Krieger was saying, these may be uncomfortable, but the people that are living with these disparities are already uncomfortable. If you are working in the field as a person of color, you are uncomfortable often. So more people need to be made uncomfortable so that we can solve these problems. So I'm very much an advocate of community-based participatory research or some kind of community engagement. And it's very key to figuring out, identifying what the issues are, and then figuring out how to solve them. And so community engagement is not necessarily only one thing, it's a continuum, but it's including the community in some span in terms of the research or data gathering in some way. And it will help to really identify the right research questions, how we can gather the data effectively, how we analyze the data, and then how we can have interventions or solutions. It really needs to include community members. They are participants, they are not subjects, and it's been too long that it has been, the ivory tower or the government, pulling all the strings. And that really needs to change. I think it's also very important to understand that community knowledge is valuable. It is not biased. Community work is not biased as well. And that's still prevailing in terms of research and even getting things funded. So researchers have to understand that everyone comes with their own biases, and it's not necessarily something that's bad, but you need to acknowledge it so that you can deal with those. So community engagement is really important, and it will also force us to have sharing, and then shifts in power is going to be required in order to carry out that kind of research and advocacy for the people who are most affected.
Oh, so time?
We have 1 more minute.
Okay,
Yeah,
real
please,
quick.
Dr.
Okay,
Mayfield.
no problem. So I believe totally, I agree with centering the voices, and ideas and experiences and expertise of those who have been most marginalized in our spaces and places. I also, though, fully believe in order for, transformation to happen at an institutional level, the culture of the institution has to change. We can train. I think it's critical we train. We have to do all of those things. That is actually a critical part of the work to changing the individual. I know we say in the context that the group and the population can move together and we can have movements, but the reality is, because there's so many leaders that are white leaning or white, identify as white, who are not used to having these conversations, there has to be individual level work that happens too, that has an intention after a while to actually want to change and shift the culture of their institutions. If that culture does not change of the institution, this work is not sustainable, and it's not even healthy to do. And it doesn't provide psychological safety. or space within the institution, you end up actually traumatizing oftentimes the workers and the public health workers, the physicians who want to do this work and want to do work of anti-racism in a way that's helpful and meaningful. But if we don't focus on the institution and changing the culture and evolving culture, we don't have much success from my point of view. And so that, there's work at multiple levels. And I think that the full frame is what's really critical. And this is the last point that I'll just say, because I am in the space of medicine and I understand kind of this divide so much greater in being in the medical space now. But I fully believe that, in order to get this bridging to happen better between public health and medicine, our medical training has to change. It has to incorporate this context broader than the clinical walls. And that to me has been the biggest gap from the medical side, is that there's just not an appreciation of public health and what it means and what it stands for. How does it show up? What's it connected? What does it do for your patients on a day-to-day basis? And I think because there's so much power within the healthcare space, that is the narrative that has been propelled for generations about what creates health, just what happens in the doctor's offices. And if we don't train students differently, that's just going to continue. And I really think that's fundamental for us to really address and even get to the point of anti-racism work from my perspective, just from being here.
Thank you so much, Dr. Maybank, for that. I have been informed that we do actually have a little bit more time, so I apologize, and I really appreciate your remarks. Dr. Krieger, do you have any closing remarks for us?
I'd like to build on both the comments that Dr. Fuller and Dr. Maybank have made. I think that it's critical to us understand also when we say public health, the public health itself is riven, that there are people that are very myopically focused on lifestyle, for example, and completely ignore social structure and completely ignore the kinds of environmental exposures or frame them as just something that is, I don't know, environmental scientists look at and they're not a part of what public health does or connects to urban planning or connects to economic policy or to any of those other things. So part of it is needing a much more integrative approach. And I think it's also understanding which data have clout. And the way that I'm coming to think about things right now are the embodied truths that make a real difference. They're embodied truths, they're not opinions, they're represented in the population rates of health inequities and also overall patterns of health. They are actually contestable data in legal courts, they are contestable in policy. They count, they're not just opinions about what's wrong, they are the demonstrated bodily evidence. We are seeing that absolutely in COVID right now. Now, who makes those data have meaning? That's going to be the combination of social movements and also their allies inside the different institutions that are being discussed, whether it's government, whether it's healthcare institutions and others. So it's understanding what become actionable data. And that also means understanding always the two-edged sort of data. As was discussed earlier in this panel and earlier today, people use data on quote unquote race to discriminate adversely. But you can also have anti-racist science that uses data on racialized groups to demonstrate an unjust harm and make it actionable and legally actionable and policy actionable. So I think those are ways to think about it. This bringing in of the historical red line is not merely an interesting historical artifact or gives us a better context. It actually makes for government liability because government was behind the redlining maps. If government is the actor, you're in a whole new category of possibilities as compared to private citizens so-called discriminating. So I think that also means that the training that we have to be and get is not only about the racism built into many measures, the anti-racism that we built to get much better structural measures, but also who do we have to work with in and outside our respective fields, whether they're in public health or in medicine. It's been eye-opening to me to work with more people in urban planning, to talk to lots more legal scholars. And this brings back to the fundamental, to me, point of the FXB Center, linking health and human rights, because human rights gets you immediately into whole sets of other doctrines of law and of norms that are crucial for understanding who you need to be allied with. So I'll end there, but I think that that's a place to bring some of these things together and understand that the data are never straightforward. Remember, the meaning of the word data in Latin is the past participle of dare, to give. Data are never a given. People construct data, they use data, they analyze data, they interpret data. Doesn't mean you make up data, although some people do, and they should get penalized, and they often do, but not always. But you have to understand the societal production of data, about the societal conditions that create what is observed with those data.
Thank you. Thank you so much for those closing comments from each of you. Thank you for the call to action. And thank you all for your time and sharing your expertise with us. I learned a lot from each of you, and I hope the rest of our participants did as well. Dr. Bassett.
Thank you, Dr. Jimenez. And I didn't explain to people that you're in the faculty of the Department of Epidemiology at the School of Public Health, and also have a post at Brigham and Women's Hospital. And we look forward to having you work with us at FXB. Well, thanks again for another truly engaging and thoughtful discussion, Monique, for moderating it, and the panelists for your remarks. We've had a really rich day. It's done everything that I hoped that it would do. It's really displayed groups of both activists, advocates, and scholars to show that this challenge we have before us requires deep and critical scholarship, engagement with communities, and willingness to participate and speak out in our broader society. So I'm going to pass the virtual mic now to Dr. Natalia Linos. Dr. Linos is the executive director of the FXB Center, but to me, she's been a thought partner as well as an implementer over many years. We worked together at the health department and write together. And I asked her to join us and give a few thoughts of the day. Not an easy task, I think, but still, we want to leave you with some things you should take with you. Most of all, the work continues. Thank you, Dr. Linos, for agreeing to do this. And
thank you.
Let me pass the mic to you.
Thank you, Dr. Bassett, and thank you again to the hundreds of participants who joined us today. And as Dr. Bassett said, I have two tasks today in closing us out. The first is to briefly summarize some of the key messages from the symposium, although I will clearly be unable to do justice to the rich discussions we have had. And so I'm happy to report that this will be recorded and available on our website within a couple days. I also have a task, which is to thank the many people who worked behind the scenes to make this event possible, including Veronica Lewin, our Director of Communications and Public Affairs, Liz O, who has joined us recently as the program coordinator for this work on racial justice, as well as Anjali Patel, Megan Daly, and Rebecca Shin, and many others. So thank you to them. So we intentionally began our symposium today with a conversation on history and the historical determinants of health and health inequities, focusing primarily on the US, even though this is a global conversation. And Professor Hammond spoke about the reality that there have always been health inequities in this country, and described the impact of our fragmented public health system in perpetuating those disparities. And Professor Mohammed also talked about the punitive ways that health, or actually poor health, was dealt with historically. Using an example of tuberculosis, he spoke about the ways in which public health was used to exclude, to quarantine, to deport, to segregate. And sadly, that history is echoing today. It's happening today when Title 42 is being used to deny asylum and seekers and expel migrant families from the US, misusing public health as a rationale. And this is being seen with the COVID pandemic across the globe, whether it is the Roma in Europe or refugees whose movement is being restricted, or increased surveillance, punitive measures policing, including where Dr. Barber talked about for favela dwellers in Brazil. The next panel took us to Dr. David Williams, who showed clearly how structural racism and residential segregation has shaped and continues to shape both opportunity, economic, educational, and health, and reflected on some of the challenges we face to move forward, including in terms of public perceptions. Who is responsible for poor health outcomes? Is it behavior, culture, and how much we have to push to talk about the structures that actually shape opportunity? Dr. Habib Nakhvi brought us to the UK and the NHS, and the lack of attention to what he called the causes of the causes, describing a need to turn evidence into action and bring about change in similar challenges that we are facing in the US, For example, noting that in the UK, Black women are more than 5 times more likely to die in pregnancy than white British women. And also calling us to really think about what true community engagement and leadership could look like. And finally, Dr. Cheryl Barber took us to Brazil, showing the complexity, both in terms of geography and even how people self-identify during political and historical movements. She urged us to think about radical solutions and what embodied resistance could look like, and how we as academic researchers could partner with social movements to bring about that change. And that is ultimately what we view as the task ahead for the FXB Center. After the break, we moved to the panel, our final panel on anti-racism and public health policies and practice, spanning a conversation of environmental racism with Dr. Fuller talking about the ways in which we frame research and action in partnership with communities, reminding us that communities are participants with valuable knowledge, not subjects, and how deliberate historical decisions, for example, where to place a highway, shape environmental risk. To then Dr. Maybank, who reflected on how race-based medicine is still being used, with race too often used as a proxy for biology, including through clinical algorithms. There, she explained how researchers, associations, along with organizers, are pushing for greater transparency to reevaluate and ultimately change such standards that are harmful. And Dr. Krieger reminded us that fundamentally, counting is about political power, and the ways in which data around race as defined by the census can be used or misused, especially when in isolation of context. She talked about COVID, our missing data there on race ethnicity, which can both undercount and distort our understanding, whether around vaccinations or even death. And Dr. Krieger, I do want to thank you as being someone who has really shaped my way of thinking around this work. So let me end by saying that while the conversation over the last 3 hours has been truly difficult, especially because of the way in which so many of our speakers have talked about history, the longstanding challenges that lie ahead, I'm also leaving the symposium with hope, and I wanted this slide to be up when I talk about the hope, because as Dr. Bassett said in her introductory remarks, there has been a shift, possibly because of COVID, possibly because of other movements coming together, that this conversation is possible today. And we have a new cohort of what I will call scholar activists who will do the rigorous methodological research, but also join in partnership with community, with groups to ensure that what comes out of Harvard, the FXB Center, what comes out of academia is really able to transform what we see on the ground. Because data, as Dr. Krieger said, is political, because research must be actionable, because all of us today hope that in the future, we're not going to be describing the challenges of structural racism in health, but really talking about the solutions that we helped bring forward. So with that, let me thank everyone again for joining the FXB Center in launching this new, really inspirational initiative under the leadership of Dr. Bassett and with the support of the JPB Foundation and so many scholars who have participated today. So thank you so much for joining us today.